starting with how do we treat a patient that shows up that is accidentally ingested. So I've shown this slide a couple times, but just to remember that this is already occurring. And what do I mean by that? We do have a lot of reports of either accidental ingestion, in animals that can get into pretty much anything. And as we, as a society, grow to have further access to psychedelics, it's a good chance that there'll be increased access for our pets as well. And so in last year, ASPCA released their top 10 toxins, and recreational drugs being number 10, but it's rising, it's growing. And so we are getting increased exposure. So again, I do recommend having a read through that and as we go into further discussion. It is critical to obtain an accurate history in order to gather information about the animal's environment, amount of exposure, time from exposure to onset of clinical signs, as well as type, severity, duration of clinical signs. So first step is taking that ever important history and some of the really important questions, as I kind of read in that quote, right? What did they get into? How long ago and how much? Then, of course, your physical exam, kind of almost an anesthesia-based exam, right? Going from head to tail, looking at their demeanor, their neurological status, looking at their CRT, their perfusion rate, like getting an auscultation, temperature, kind of our basics, right? They may think that their animal has gotten into one substance, let's say MDMA, one we're going to go into a little bit. They might think that that's a pure substance. There could be other additives in there. And things like caffeine, okay? That's going to make it much more dangerous for our patients who are very sensitive to caffeine. I discuss owner intoxication, and so if the animal got into something, is there a chance that they had it out because they were also using it as well? This could be a little bit more tricky, a more sensitive situation. Ideally, having a veterinary social worker, if they were on staff, would be a great person to have introduced into the conversation, even taking all this information into hand, going back to your clinical symptoms, your signs, what are you seeing, and how can you support that patient? Okay, so let's say we have a patient that has eaten any of the substances we're going to talk about. Do we induce vomiting? I would say yes, if it's within the window that that you think is appropriate, and that is going to change based off of each substance, unfortunately. So, again, how long ago did this happen? But what was it? Was it a synthetic molecule or a plant molecule? So synthetic, MDMA, LSD, something like that, is going to be pretty rapidly absorbed. And so we're given maybe a 30-minute window. I would say LSD even quicker. And so that's going to really depend on how quickly this patient received this, or how long ago this patient received this. And then for plants, you might have plants and fungi. I'm going to put that both together. So plants and fungi, you might have 2 to 4 hours, right? They were listing 4 hours. To me, that seems pretty extended, but it would depend on how much was actually eaten. So I'm going to say more around that 2-hour window, okay? And for me, this is actually less important of time, but what clinical signs are you seeing already, right? Is your patient seem pretty normal overall? Then it's induced vomiting, less risk of aspiration, and trying to get that substance out of the body. If clinical signs have already taken place, especially if you're talking about LSD, MDMA, then the neurological status of that patient is going to be altered, and inducing vomiting could actually be a bit of a risk. I guess also the client as well. This is going to depend. I think part of this, good first aid at home, to be able to induce vomiting at home if an animal got into someone's stash could be much more appropriate given some of how quickly the onset of some of these drugs can be. Okay. Route of administration. I mean, this is always going to be important to know. We're talking more here about oral ingestion and where vomiting is going to be appropriate. But a clarifying question, right? Was it, potentially inhaled or insufflated as well? That's maybe going to change your approach, and vomiting is not going to be appropriate there. From there, as part of a regular decontamination protocol, We would, in the ideal situation, go into whether activated charcoal is going to be proper or not. For a lot of use, I wouldn't be rushing to give activated charcoal. I am not sure about the binding of, say, LSD, MDMA. I don't think charcoal is going to make too much of a difference. Psilocybin, maybe, but if you've induced vomiting, then and everything's okay, then I would probably give activated charcoal, that initial dose with the cathartic or sorbitol to help things pass through. So this biggest takeaway is that pet stable. Then I would say go for it. If they're not, then I would be a little bit more cautious, and treat the symptoms or treat the patient. Going back, let's say we're not having an absolute crisis, or we're not suspecting serotonin syndrome. We're suspecting, let's give an example of the patient got into several grams of psilocybin mushrooms, appears normal, but we do see a psychedelic effect that is pretty profound. And so the patient's already, several hours into this. How do we treat it? And so what's a specific way to monitor a psychedelic patient in this framework? I think IV fluids, venous access would always be safest. Remembering to minimize stimulation overall, dim lighting, even calm music, and then keeping them nice and warm or thermoregulated. Vital monitoring, heart rate, respiratory rate, SpO2, blood pressure. I put this, but I also wonder, right? I wonder about the discussion, and really excited for input of being too hands-on versus hands-off, right? And I can only take this from kind of a human-centric point of view, being handled in that specific state, bright lights, things like this, poking, anything you're going to be, could just make things worse for that patient. So it's really going to come down to clinical judgment and what you think is appropriate. And of course, how much you trust the knowledge that you received either from the owner. But I think it's something for us to discuss and consider. And so I actually consider or think about this in kind of a pre or post anesthesia care, and that it's not much different for me overall. Especially, let's talk more about the kind of post-operative care or anesthesia assessment. And I take this from, if you can see it, so this is from some RAVs, so a wonderful group, and I use this with their permission, of their beautiful chart that they've laid out of assessing anesthetic depth from stage 1 to stage 4. Stage 1, just kind of a quick recap, being kind of a pre-anesthesia phase, or we're not going to see too much changes, but and the patient's not out completely. But there might be some changes in vital signs, maybe their pupils change, things like this, and then going into a stage 2, that excitatory phase, or I'm going to say dysphoric type of phase, which we also may be able to see in the psychedelic phase, and then getting into kind of anesthetized phase. I would think we're going to be more in stage 1, stage 2, maybe a light anesthesia phase, or might mimic kind of a light anesthesia phase if they're pretty out of it. But they should still be responsive to stimuli. Anything beyond that, yeah, that would get a little bit scary. I would think of more contamination, or if we're talking super high doses in some of these patients. So I think this is a good chart for us to refer to. And let's say we have our patient, we're monitoring it. Can we use these kind of charts to start to classify, to start to get an idea of what are the psychedelic effects and relate them to what we already know and are comfortable with? And so that's how I will sometimes approach these cases, depending on the situation. Okay. And then what about follow-up care in general? Let's say your patients have done well, you either decontaminated them or not, depending on the situation. They've recovered well, they're going home. we're all happy, but what about long-term or follow-up care? And so I think this is where it gets kind of more interesting. And this is what we'll go to in the next discussion group in a couple of weeks, because we think it's really important. We're knowing that these psychedelic experiences can reopen critical periods in these patients. And depending on the substance, depending on the amount, that could be weeks to months. And so us having a better understanding of this, I think will help us also approach our clients to be able to say, yeah, this happened now, but we're not quite sure what's going to happen over the next 2 or 3 weeks. It could be, in some cases, a great opportunity to find new behaviors. If there's any kind of inappropriate behaviors or difficult, challenging behaviors within that patient, maybe that's a great opportunity to work with a trainer or behaviorist in that situation. Or are there negative consequences of this that we're seeing within those follow-up periods as well? We don't really know. And so I think this is a good starting point for us to at least have the discussion. And then I'll post more on not this Monday, the following Monday before the next group, and we'll go a little bit more into what this actually means. What is this critical period, and start to discuss how is that going to potentially show up for us as animal health professionals. Good. That's all I have for today. And feel free to reach out if there's any questions that you want to bring up outside of this or any concerns. Please let me know. I'm always happy to chat about that.